Okay. So as I have said before, when we're taking care of a postpartum family, our focus is going to be assessment and support of the mom's physiologic and emotional adaptation after birth. And again, our focus and our approach is wellness oriented. Many of the things we're going to do besides assessment are basic care, basic health, assisting her with rest and recovery, monitoring and assessing for physiologic and psychologic adaptation. A big focus is preventing complications, catching things before they're a problem, educating her about how to take care of herself and her baby, supporting her as well as her partner or support person during this initial transition to parenthood, and then aiding the family at large in adjusting to a new baby through care plan strategies. Okay, so every hospital is a little bit different. Many do couplet care, where the same nurse is taking care of the mom and her baby. That's couplet care. Occasionally, you'll see a setup where there's nursery nurses and postpartum nurses, and so maybe the postpartum mom or nurse has 7 moms, and the nursery nurse has the 7 babies. And so that family would have 2 nurses checking in. Just depends on the approach. So here is a list of all the many things that we're going to pass on in couplet report. Who the doctors or healthcare providers are, or grab the care numbers, how old she is, what anesthesia was used for her delivery. If any medications have been given after delivery, that needs to be passed on. Okay, notice the next one says time of ROM. What's ROM? It's rupture of membranes. So we're going to shift to that. Wrong. Why do you think if I'm going to take care of a postpartum mom, why in the world would I care about when her membranes ruptured? That's her water breaking, just to clarify.
How long she was in labor.
Okay? And honestly, we care about how long her membranes were ruptured, because the longer that they're ruptured, the increased risk of infection.
As long as it's been ruptured before birth?
Yes. So let's say that her membranes rupture at 1 a.m. and she doesn't deliver until the next day at 6 a.m. How long is that rupture of membranes? Say it's the next day at 1 a.m. Or
Oh, the next day.
Yeah. So say they
29 hours.
29 hours. That's a long time.
What's like a normal time? Not really.
There's not a normal time, but to answer your question, every facility is a little bit different, but a lot of them will have an order in place that if a mom's membranes are ruptured for more than 18 hours, they'll have an antibiotic protocol at the start. Some will wait 24 hours, but a lot of them do the 18 hours. And so the other thing to keep in mind is even if mom is fine, the baby could get sick, right? Because that was a direct line of infection of the baby. So it's just something to note. We provide details about labor and delivery, the type of birth, and then if it was a vaginal delivery that had some sort of laceration or episiotomy, we talk about what repair. laceration, or what kind of repair was done. What is mom's blood type and her RH status? What's GBS? Good job. Group B strep. You may sometimes see GBBS, group B beta streptococcus. Who the heck cares about that? What is that? What'd you say, Olivia? Yes. So GBS is the type of bacteria that about 25% of women naturally carry in the vagina area, the perianal area, and it is normal flora for some women. The problem is that if it passes to the baby during delivery, it can be lethal. So, around 35 weeks of prenatal care, all pregnant women will have a GBS swab done. It looks like a cotton-tipped applicator. They'll insert it in the vagina, they'll rotate it around, and then they'll rub it posterior over the anus and send it off to the lab. About 35 weeks, 35 to 36 weeks while she's pregnant. And then when that report comes back, that tells us, if she goes into labor, what her GBS status is. So if she's GBS positive, we will treat with antibiotics during labor. The gold standard, if somebody's GBS positive, is to get 2 doses of IV antibiotics in before the baby's born. And for whatever reason, they don't tend to start these antibiotics until she's in labor. Don't quite understand why they don't just bring everyone in with their medicine.
So what if, like, you would come in, say, at like 30 weeks and you were delivering? They just
So-
treat it with an antibiotic just in case?
Yes, if they haven't checked yet, then they call it GBS unknown and they treat it prophylactically.
And what, you said it's lethal to the baby, what does it
It
actually?
can be.
Okay.
Group B strep, if it gets into the baby, if it can cause systemic, significant sepsis.
And so if the baby's born and say it was like really fast, like you had no time to
Right.
even do any of that, would you then treat the baby when they get
Not
out?
necessarily, but we just watch them closer, which is why we pass on what the GBS status is. And we typically say she was GBS positive and got 1 dose. She was GBS positive and got 5 doses, whatever it is. So that communicates to the receiving nurse, I gotta watch this baby closely. And, usually if they're GBS, if the mom was GBS positive, then we do get vital signs on those babies, every 4 hours for like a 48-hour window.
Okay.
I had a friend who even after the 36-week testing, she had caught it.
Oh.
And so she delivered a baby got it and luckily they caught it, but the baby was in the for like.
Yeah, I always remember, so when I worked at Boone, the provider, the doctor, Dr. O'Connor, who started the NICU there in the late 90s, he always told us that he will retire when GBS bacteria no longer responds to penicillin. He said he doesn't want to be around when we don't have antibiotics. And that always stuck with me, like, whoa. So, the thing to know too about GBS disease in babies is it can sneak up quickly. And remember, babies don't communicate illness the same way adults do. They don't get fevers. They typically tell us with fast respirations. Or they'll get lethargic, or they won't eat, or their blood sugar will go out of whack. Okay, rubella immunity status. You guys submitted submitted your med profiles this weekend, which means there was an MMR or a rubella vaccine on there, which means you guys can tell me why the heck we care about rubella status. So lay it on me.
Can lead to heart complications in that baby.
What'd you say?
Lead to heart complications in the
Okay. Tell me more about that. Good job. What you guys put on your red profiles? Why do we care about her rubella immunity status?
We want to treat kids so that they don't possibly get rubella.
You know, that is the correct answer for some of the vaccines, but not this one. Who does rubella do the most damage to? Unborn fetuses. Rubella as a disease is teratogenic. Yeah. We are not afraid of the newborn baby that was just born getting rubella. That is not what we care about.
The next pregnancy.
Yes. Rubella is unique in that as a disease, as a contagious disease, most of the harm it does in society is to unborn fetuses. Okay, so when a mom starts prenatal care, she's gonna get a lab slip and get a bunch of blood work drawn. Blood type, all sorts of stuff. And one of the things they're gonna check is if she's immune to rubella. Now, here's the deal. Rubella is a live vaccine, which means you can't give it during pregnancy. If she's already pregnant and she's not immune to rubella, there's not a whole lot we can do to stop, to fix this pregnancy status, except teach her how not to get rubella if there's rubella outbreaks, which thankfully there aren't a lot. But what we want to do as her healthcare team is immunize her against rubella when we know that she's not pregnant. And isn't the best time to know that someone's not pregnant immediately after they deliver a baby? Pretty hard to get pregnant right after delivering a baby.
I can't remember, do you get it after each one or is it?
You get a titer done with each pregnancy.
Okay.
So, one time I was with a student at St. Mary's and we gave the MMR vaccine to someone who had their fourth baby. And I kept thinking, how in the world is this mom a gravid of 4 and still not immune to rubella? I don't know. Okay, so we care about rubella because we are trying to protect future fetuses she might carry the rubella by making sure mom is immune. I guarantee I'm going to test you over why do we care about which vaccines. What questions do you have about why we care about rubella status? Happy to explain again if I need to.
So what about the first baby? Like, just, like you make sure that she's like vaccinated before she gets pregnant, or the first one?
You can, like you guys who haven't had kids yet, you know, you can get some of you have gotten your titers checked with school and you make you get vaccines if it's negative, or if it's not positive. But no, there's not like a standard protocol for non-pregnant women to get that.
Would you say the first baby is the higher risk of getting it?
Yes. I would say that, but I would also say that most women who have had both MMR vaccines are immune.
Okay.
It's relatively rare for someone to be non-immune if they've been vaccinated. A lot of what we see also is something called equivocal where it's that middle range where there's a little bit of immunity, but not enough to mount a response. So if they're rubella equivocal, we also treat them. But because it's a live vaccine, we cannot, once they're pregnant, we can't treat them during that pregnancy. We have to wait till they're postpartum, which is why the postpartum nurse cares, because she's gonna be the one to give that vaccine. Okay, is everybody follow me? Okay, so we all understand that if we're giving the MMR vaccine to a postpartum mom, it has nothing to do with the current baby she just had. It has everything to do with her future fetuses she may become pregnant with. And we cannot give it until postpartum because of the live vaccine. Okay, any other current infections, HIV, Hep B, chlamydia? Does she have any IV infusions running? Any assessment details that are pertinent would be important to share. Fundus, lochia, bladder, perineum. And then we'll move on to the infant. So what sex was it? How much did it weigh? When was it born? How is it feeding? Is it breastfeeding, bottle feeding, both? When was the last feed? How are the parents interacting with the baby? Anything abnormal on the baby's assessment? Hopefully one thing you gained from Super Lab last week is that there's a lot of normals on a baby assessment. Some babies will have milia, but if they don't, it's okay if they don't. But milia are normal. You know, there's lots of different things like that. So there's a wide range of normal, but if there's anything abnormal, that needs to be passed on. What were the APGAR scores? Has it peed and pooped in its lifetime? And then which nursing interventions have been completed? You know, has it gotten its vitamin K injection? Have we done the first bath? You know, whatever else is needed. If it's getting routine blood sugars, when is that due? That sort of thing. Okay, questions about that? Well, okay, then if you guys are ready, I'm going to give you a report on a couplet, and I want you to tell me before you hit the ground running what kind of stuff you'd be planning in your day when you take care of this couplet. Are you ready? Give me your report. Ready? Not everyone at once now. Yes. Okay. All right, here's the report. And when we're done with this, I want you guys to tell me what caught your attention and what you'd be thinking as you take over care on this couplet. All right, Vivian Bertolotti is 26 years old. She's a Gravida 2, Para 1.
26 years old?
Yeah. She's a patient of Dr. Brenton. She has no known drug allergies. Her blood type is AB negative, and she's rubella equivocal. She was admitted this morning at 00:30 for active labor. And she delivered vaginally today at 04:43 in the morning over a 3rd-degree laceration. She had an epidural, which is now out. She was GBS positive and got 1 dose of antibiotics. Her estimated blood loss was 450. She received 800 micrograms of Cytotec rectally after the placenta delivered. Cytotec. We finished her full bag of Pitocin around 06:30, so she is now saline locked. Her bleeding has been light since. Her fundus is firm at the umbilicus and midline. She has voided several times on her own. 8 pounds, 4 ounces, and was 20.5 inches long. Her APGARs were 8 and 9. Her blood type is B positive. Her
What type was it?
B positive. Her assessment is unremarkable, except for a dimple on each earlobe. She does have noticeable newborn rash on her torso and legs. Her vital signs have been within normal limits. No blood sugars or special orders are in place. She received the vitamin K shot and erythromycin following delivery. Parents wish to defer the first Hep B vaccine until they see Dr. White in the office. Lillian urinated at birth, but has not stooled yet. They are breastfeeding like champions. They have completed 3 great feedings so far. The last feeding was at 08:30. The feeding went well, great latch. Baby was awake throughout, 20 minutes on each side. Okay, so that's the couplet you just got report on in clinicals. What are you thinking as you shape your day? Okay, why do we need Rogaine?
Mom's negative. This is on your baby's house.
Okay, so we're gonna give Rogaine. We'll talk about all the ins and outs of what that is, but you're correct. So they're gonna need Rogaine, so we need to put that on our to-do list for the day. Okay, so Kylie, is saying because mom was GBS positive and only got 1 dose. This was the first baby she gave birth to, right? She was a pair of 1. And she got here at 12:30 and delivered like 4 hours and 40 minutes, 4 hours and 13 minutes later. So they only got 1 dose in. Usually those doses are every 4 hours. Okay, so we need to watch the baby closely for symptoms of infection. Okay, yeah, if she signs the consent, she does need a rubella vaccine. Why? Yeah, it's not high enough to consider her status to be immune, and she's still a childbearing age woman. What else? Okay, see what she needs for that, sure. Okay, are we worried? We're not worried, but it's notable. It's something to just make sure we know when it occurs, sure.
You want to keep an eye on her, but she has got that couple of times.
Yeah, so she's probably good to go with getting up. What would you want to talk to her about though, as far as getting up? Okay? Yes. What would we want to, why do we care about everyone's bleeding, but what about her makes us cautious? On the right track.
She's using Marshall, so she's already lost.
So that's a good point. Lisa brought up that she took Norco, which has got a narcotic in it. So you're saying just from a safety perspective, right? Can it make her dizzy? Yada yada. Okay, sure.
She already lost 450 pounds.
Yeah. What do you think about the 450? It's really darn close. And 450 is quite a bit for a vaginal delivery. What else is notable related to that? Yeah, they finished a whole bag of Pitocin after delivery. And what else did I say they gave her? Side attack. What the heck is that? guys actually learned about it in farm. So it's misoprostol. It's an old school anti-ulcer drug. We use lots of stuff in OB off-label. And one of the side effects of misoprostol is it helps empty the uterus and get things out. So it controls bleeding. So they gave her 800 micrograms of that after delivery, which tells me as the nurse that wasn't there during the delivery, the provider was worried about bleeding. That is not routinely given. And what I'm hearing is that now everything's under control with bleeding, but my alert sensors are up, and I'm gonna still watch her closely. And I wanna make sure she knows what I wanna know about. If you pass me clots, I wanna know. If you're filling this pad up quicker than 2 hours, I wanna know. If you think your bleeding's getting heavier, I want to. So make sure she knows that. And again, we care about that on all moms, but she's already got red flags telling us she's at high risk for an hemorrhage, right? Okay, what else are you thinking about this family?
You should incorporate data teaching.
Okay, sure. If mom has a 3rd-degree laceration and has lost that much blood, and I'm guessing they messed with her uterus quite a bit to make sure there was no placenta inside, she might not be feeling super great. So that's especially important to tie Gerard into diaper changing, holding the baby, keeping it content, etc. Okay, what else?
But you don't want to have any shock.
What do you think about that?
Just to make sure mom doesn't. Yeah, just make sure she doesn't have to do herself. But that would be passed on. If mom did have that, they probably would. Okay, what else? Yeah, it's still her first time breastfeeding, even if it wasn't, it's a new baby. So it's great that feedings are going well. Keep supporting them. Keep assisting them. What else? Yeah. I called it newborn rash because that's what nurses call it. I'm sure you guys learned. Yes, erythema toxica. Thank you. That is a very common rash, and a lot of people call it newborn rash. But parents often think, oh no, the baby's got chickenpox, or the baby's got something, and they don't. But it's notable just to pass on a report so that the next nurse knows what I found during my assessment. What else did I say about the assessment of the baby? Yeah, who the heck cares? Why would they pass that on?
On each earlobe.
On each earlobe, who cares?
So just like it, like you need to.
What do the ears look like? What do the structure of your ears look like? God, I used to love tying this when I taught farm before. Okay, in utero, guess what? The ears form at the same time kidneys. So in farm, we learn that a lot of drugs that are ototoxic are also nephrotoxic. And they're shaped similar, right? So sometimes when we see odd things on ears, we're concerned is something wrong with the kidneys. They were formed at the same time. They have skin tags. If something looks different. Isn't that cool? I think it's fascinating. Now, there are many babies born with cute little nuances on their ears who have perfectly, beautifully functioning kidneys. This child's already peed, right? That's a good sign. But it's just notable. sometimes doctors will order like a KUB scan or something, just to make sure.
What about, did you say she was a gravid too?
Yeah, so if she's a gravid 2, para 1, I only gave you those 2 letters, I bet we can figure out what the rest of her letters look like. What do you guys think? Yep. Yep, let's do it. Okay, so what did I say, gravida? 2, para 1. Alright, let's fill in the rest. I don't think I said how far along that thing was, right? I did not.
She could weigh 8 pounds more.
Doesn't
Yeah.
matter, she could theoretically have ginormous babies. But let's say she's 38 weeks and 4 days.
But what about, is this pair of one?
That's postpartum report, yep. So when you get postpartum report, they will have updated these from the current delivery. So she's now a gravida 2, para 1. When she got to the hospital, what was she? 2, para 0. When she got to the hospital. Now she's gravida 2, para 1. Term 1. Good. Good job, guys. That was application. Okay, anything else you're thinking about this family? What? Yeah. What are you thinking about that? What? Oh, okay, gotcha.
She would be really emotional because it's the rainbow baby.
Oh, yeah. You're right. So she may have heightened risk for postpartum depression. Right? Sure. Her labor also went really quickly, so she didn't have a whole lot of time to adjust. That's a good thought. Anything else? Those are good efforts, right? Okay, good job. Why don't you guys take a 5-minute break?
I would've waited, I'm sorry. I didn't know where you got that.
Oh, no, I usually, that's a good signal. Because after the quiz, I thought it was a little early for break.
Yeah.
And then, and OB is no different. It's important to do ongoing physical assessment. We don't just do one assessment and say, okay, I've documented it, and then it stops. You do one, oftentimes shift assessment at the beginning that's a full head to toe, but then you're constantly assessing your patient as you talk to them, as you check on them, etc. A lot of times that acronym bubble P is used for postpartum assessments. We went over that relatively thoroughly during Super Lab. On table 19-1, page 469, that's the table you guys should have utilized for that question on the Super Lab ticket that goes over in the left column what the normal findings are, and then in the right column what those could indicate. I do want to talk briefly about, I realized after Super Lab I didn't really go over some of the neuro things that we check. We often check deep tendon reflexes. Have you guys done those with your med surg patients? And if so, which deep tendon reflexes do you do? Okay. Do you usually do that when they're sitting up or when they're in bed? Like dangling? Okay. When we're in lab, I'll show you guys. I often do it when they're in bed, and you can just support the upper part of the leg and check it. And how do we rate or how do we document reflexes? Like how would you, if you do a patellar one and you got a normal response, how would you document that? No, it's not a positive, negative.
Is it just absent or?
That's one possibility, but there's usually a 0, 0, 2, 3, 4 plus. 4 plus. So a normal one is 2 plus.
That's the same as the post.
Yeah. Here. Would somebody want to come up here and be my patient that can create like this? Pseudo bed. So there's a couple things I'm going to show you guys. Anyone. It would require allowing me to touch your leg. So only if you're okay with that. Okay. All right, so she's my patient, she's in bed, and I want to check her deep human reflexes. Now, of course, someone that can move around well, you can go ahead and have them basal, that's fine. But I typically leave them in bed, and if you hold on to the bottom of their thigh, and then I always say, I'm going to check your reflexes. I don't want you to do anything to help me. Just keep your legs relaxed. And then right below the kneecap is a good spot. Okay, see that? So that's a 2 plus reflex. I don't know if you've ever had this happen, but I learned after working full time that some people think the reflex that you're checking is that when you hit them, how quickly they kick. They think it's like a purposeful thing, because have you ever done one on someone and then like a second later their leg goes up and you're like, so that's why I always say don't do anything to help me, just relax and let me do all the work, because they think the reflex is, oh, when she hits me I have to kick back, and that's not what it is. Okay, if her reflex was still there but less than what we just saw, we would call that 1 plus. That's still normal on some people. They may not have good reflexes, they may tell you that. So 1 plus or 2 plus is typically what we see. When we start seeing hyperreflexia, that's 3 plus, 4 plus. And with that, it's definitely noticeable because you can barely touch them and you see this really hyper reaction. It doesn't match like what you did. And so a lot of times when we see hyperreflexia, what do we think? What part of the body's irritated or angry? Neurological system. Yep. So with OB, we start thinking, is preeclampsia a problem? Or maybe they're had preeclampsia and we're just monitoring symptoms. So you may or may not see nurses incorporate that in regularly. Other times you may only see it done if the patient has been admitted for preeclampsia or has some sort of neurological status they're watching. The other thing I wanted to show you guys that I meant to show you in Super Lab is something called clonus. Do you remember hearing about or learning about clonus before? What'd you say?
Is it a seizure thing?
It's tied to the neurological system. Yep. You're close. You're very close. So, you know how with the Babinski reflex, we expect to see those on newborns? Have you ever noticed that if like somebody has a head injury, they'll say things like, oh, she has a positive Babinski. We don't want to see that on adults, right? If a Babinski comes back, for example, that's a problem. So clonus is another thing that we don't want to see. It is it's evidence of neurological irritability or neurological illness. I'll show you. Wait, see you guys. What is it? first I'm gonna show you what non-clonus looks like, because 99.5% of patients are not gonna have clonus, and that's how we wanna keep it. So the way you would check for clonus is I would tell the patient, pull your toes to your nose, and then let your feet go back down. And so most patients, you flex up, and then you say let go, and their feet are gonna go back to where they were. And that's what you want. If they have positive clonus, what will happen is their feet will beat. Tap. And you don't want to see that.
So it, like, they keep going back in.
They go back to where they were, but they beat on the way back.
Oh, so they like
They don't-
stagger.
Yes, yes. And so if somebody truly has clonus, you'll see them documented as how many beats of clonus. 2 beats of clonus, 1 beat of clonus, 3 beats of clonus, however many beats it was. Does that make sense how I demonstrated that? Flex your toes to your nose, and then just relax your feet back. Okay. Any questions on doing reflexes while they're in bed? So you would have to, and also I typically am a big focuser on body mechanics, so I would have raised the bed up to me. I would never ever bend down and do this because I'm old, but also it's just horrible body mechanics. So I've raised the bed, and then you're gonna support all of the weight. So her leg should feel heavy. It should feel like the dead weight of an adult leg, and you're holding it under the thigh, because that's what's gonna allow this to dangle. And then right below the kneecap.
So are we checking the clonus?
Usually, what I've been seeing is trends lately. I don't see either of these really checked unless there's a concern. I typically always did reflexes just because we did. And we used to do something called Homan sign. Did you guys learn about that? So it was really easy to do Homan sign and then check with clonus right after, because they flex their toes. You'd ask if their legs hurt, and then but I don't see, they don't check Homans anymore, and I don't really see clonus checked. Because usually clonus, that's a late sign of a problem.
Would you say hers would have been positive though, since
You
her
know,
feet did
she
that?
probably wasn't the best example to use, because there's a few people I've seen what looks like clonus, but I know they don't, like, so hers was kind of like this stretchy.
Mine do that too.
Yeah.
Like when you really stretch it, like if it's just up and then down.
Yeah, that
But
was
like
more
pushing
like,
when you're stretching.
Yeah.
I think my muscles are like, ooh.
yeah. I've had several patients like that where it looks like total clonus, but their blood pressure is like 100 over 60. They're not sick at all, but it's like, I've had patients or students be like, you know.
So is this only like a concern with pregnancy or
Anybody that's got a neurological ailment, they would watch, Babinski's, deep tendon reflexes, clonus, the doll's eyes thing. I mean, they do all sorts of neuro checks. You will probably only see these things if it's someone they've been concerned about being preeclamptic. But in case where you guys are at, they are doing them more routinely, at least you know how to do them and you can incorporate them. Yep.
I have a question. So we're just talking about neuro. The reason on our super lab you said
Yes.
we're looking for preeclampsia. So
We're not necessarily looking for
one of
adult
the
people.
things.
Yeah, it's a common reason we would have neurological manifestations.
Okay. So what is the difference between so they've had the baby? When does preeclampsia become
That's
just
a
like
great
blood pressure?
question. So preeclampsia, the pre part has nothing to do with birth. It can show up after 20 weeks, and it can show up in the first 4 weeks after delivery. And I'm using the word show up incorrectly. Whenever somebody finally has manifestations of preeclampsia, that just means the disease has gotten far enough that we're seeing it. You don't suddenly get it. It is a systemic disorder that has been in place for a long time before you see manifestations. So you may have it towards the end of pregnancy, and that's why we induce or whatever, but sometimes in the postpartum time, you'll start seeing these blood pressures go up, or you'll start seeing symptoms of it when they weren't diagnosed with that before. So it certainly can manifest after delivery. And we will talk about the very extensive pathophys of that disease later. It's very fascinating disease. Thank you for being with me. Did I answer your question, Sarah?
Yeah, I mean, I think we'll get into it
You
more,
asked
but
me.
basically, what's the cutoff? When does it become just high blood pressure, or is it
Oh,
just the?
if it doesn't disappear, so if you have high blood pressures before 20 weeks, they typically attribute that to something pre-existing.
Okay.
And then after, if it's not, because it's not just blood pressure. Well, that's one of the manifestations, but there's usually other symptoms.
Oh,
Protein, urea, there's lots of other things. If blood pressure hasn't gone back to normal, because there's something called gestational hypertension as well, where there's no protein, urea, no other systemic features, it's just high blood pressure. If that doesn't disappear by like your 6-week postpartum check, then they say you're probably chronic.
Did Mindy end up having that or no?
You know, Mindy, yeah, she had gestational, I believe. Yeah. She definitely had to keep getting blood pressure checked afterwards. Okay. So any questions on postpartum assessments? Remember, that's gonna be one of your lab practice things, so I thought maybe next week we could do some checkups or something, not checkups, but we could do some assessments together just to kind of show you the full flow of a postpartum assessment. Anyways, let me know if you have any questions. For laboratory testing in the postpartum time, again, I always have to keep saying this because every facility I've been at is a little bit different, but every facility is gonna have some sort of protocol on when to draw a hemoglobin and hematocrit or a CBC level after delivery. So sometimes they'll just say, do it the next morning at 6. Sometimes they'll say, do it 12 hours after delivery, or 12 to 24. But what do you suppose the purpose is of checking a H&H after delivery? Especially hours, or half a day, or a day later.
How their body's adapted to the blood loss.
Okay, it's usually a better indicator because it's given the body time to kind of recalibrate itself.
Or possibly it's like a bleed, more of a bleed than you don't really see.
Yeah, that's a good point. Sometimes, very rarely, but sometimes there's not an actual massive hemorrhage where we're like, oh, she hemorrhaged. But they go and check the H and it's awful. If it's awful, it doesn't matter what I saw, she probably needs a transfusion. I'll never forget, I took care of a mom, I think she was 19, and she had twins vaginally. And she was this tiny little thing. And when I got a report, she delivered the day before, still had her saline lock in. They don't like to take the saline lock out a lot of times until we see what the H&H is, because if they need to have a transfusion, you want to use the IV site we already have before you take it out. And she was real skittish about needles, and she was like delaying getting it drawn, yada yada. So they finally drew it, and this is crazy to me. Her hematocrit was 17, her hemoglobin was 4. And when I called the provider, he was like, and she's conscious? I said, oh yeah, and she's walking around. And we couldn't figure out how she was doing that. So I finally said, are you sure you're not like dizzy or the room looks dark when you stand? And then she finally was like, well, now that you mention it, when I stand up, the room does get kind of dark. So but she didn't have any active, I don't know, but she needed a blood transfusion. That was a very unsafe, those were unsafe numbers. And maybe she felt fine here, but she has twins and she's about to go home. What happens if she passes out while she's holding one of them or hits her head? So the H&H postpartum can tell us a lot of times even better who needs a transfusion and who doesn't, despite what the blood loss looks like.
I know my own personal offer that right after a hemorrhage as well?
Some will. Some doctors will say, you know, they'll stabilize and they'll give them meds. And some will say draw one, or others will say draw one in 2 hours, just to, because sometimes if you draw it too quickly, you're catching the blood that's say up here, and everything's still kind of recalibrating too. And like right after delivery, remember how we talked about there's massive diuresis for the first 12 hours. So I think that changes. You know, you think about women often come across as anemic because the plasma volume of their blood expands more than the red blood cell content. So if you draw their blood too early, it's going to look more diluted. If you let some of that diuresis occur, it's going to look more stable. So they give it some time. So some facilities will have a UA done. They'll have that ordered after delivery. Others won't. So if there's a routine UA that needs to be done, have that collected. When we look at our laboratory testing as part of our assessment, we're also going to look at our rubella status. And remind me why?
Future pregnancy.
Well, yes, but why am I today going to look at this, and what am I going to do with her? What?
Immune to rubella.
Okay, so I'm looking at whether or not she's immune, right? If she's immune, what am I going to do? Nothing. If she's equivocal or non-immune, what am I going to do? Yes, I'm going to make sure I've got the order, which it should be activated on all moms that are postpartum. Get consent, explain to her why, and then give that vaccine.
So you were saying it's not for the current baby
No.
at all?
No.
So you wouldn't do anything, like no cardiac monitoring at all for a baby?
Nope.
Like, no?
Because honestly, the biggest, it's fetal, so they would have caught something on the ultrasound, or there would be abnormalities. They'll do a hearing screen, so if it had hurt, they'll catch that on the hearing screen.
When you say equivocal,
What do you say?
when you say equivocal, is that?
Oh, equivocal,
Is that not?
Low level.
It's in between.
Okay.
So it basically, it's very low. There's some immunity showing up. So you had some sort of reaction, your immune system.
That's like when I had my titer, it said that I had
Yes,
some, but
I
I didn't
remember.
have enough.
Yes.
So I had to get it, I had to reget my vaccine.
Yep.
Because I was still at risk.
Yep.
I don't remember which.
And a lot of times
Those
titers
checkbox.
can go down with age. You know, maybe you had a good titer a long time ago because you had all your, you say it was your.
I think I only had one of the vaccines.
Wasn't it your MMR? Wasn't one, two of them were fine, but one was low?
It was my chicken pox.
Oh,
I only got
varicella.
one. So then I
Sometimes
had
people
titer.
have, for the measles, mumps, and rubella, two of them are fine, but one of them's low.
Mhm.
So, and it's kind of hard to get just the one vaccine. It's almost more expensive, so you need the third.
Yeah.
How do you know why they able to do the other series?
Second or third?
Second one.
Yeah.
Oh, 'cause you had a
Second.
titer.
Well, I only had one,
Yes.
and I was like, I'll just give it a shot, and then I got a titer from chicken pox. But I always, I don't think I did, yeah. Through the thing
I
I
went
went
and did my titers wrong for my reading for my.
Okay, and then our lab work, the mom's blood type, they will have checked at the beginning of the pregnancy. Why do you think that is? Why do we care way at the beginning of the pregnancy what her blood type is?
Because if they're, a blood type or?
Blood type.
a negative, if you're negative, then they have to get the organic during the pregnancy.
Okay, so they, correct? Why else? But why, that's not till 28 weeks usually, so why are we gonna check it way at the first appointment?
In case they need blood.
Okay?
If it's a second pregnancy and they get a baby.
What'd you say?
If it's a second pregnancy and they didn't get more indicated than the other
Okay. Do you think if I have a miscarriage before I make it back for my second appointment, they need to know if I'm negative or positive? Because if I miscarry, there's likely to be blood mix, so I would be rhodium. It's not a happy reason, but it's necessary. Okay, so we need to know mom's blood type from the beginning. As Kyrie just said, and we haven't covered this yet, but we will now, I guess. Until we know the baby's blood type, we have to assume the baby's positive. And we we treat all moms with negative blood types as if their baby's positive. So we go ahead and give them Rogan at 28 weeks. Okay, then at delivery, they're gonna draw blood from the cord and send off a blood type for the baby. And then if the baby shows up as negative, what are we gonna do? Nothing, and that means the dose she got at 28 weeks was nothing. If the baby shows up as positive, what are we gonna do? Give Rogan. Yep. Okay, infant security. This is part of assessment. Remember that assessment is not just body parts. It's what's the body doing? How is she acting? What are lab results telling us? And then on this unit, infant security is part of assessment. So when I say infant security, what kinds of security is there? What does that mean, infant security? Yeah, they should have two forms of identification or two security, infant security measures. The first one that we call like the ID bracelet, that's the one that at delivery, you'll see whoever's assisting getting like 4 different bracelets ready, and they're gonna have some number that matches amongst the 4. And they usually jot down details on the bracelet too. If it's a boy, if it's a girl, the mom's name, date, time, that stuff. Where's security listed on this one? Where are those gonna go? The ones with some numbers. Okay? So 2 will go on the baby probably, either both legs or 1 on the wrist, 1 on the ankle. 2 of them in case one falls off. And then the mom for sure will get 1. And then a support person of her choosing. And it can't change once it's on. They can't flip it to different people. So if it's often like a dad type of figure, maybe her partner, maybe her mom or a cousin or a friend if she doesn't have a father of the baby or parent of the baby involved. So those 4 are how we prevent switched at birth issues. Those are to connect that mom to that family, or sorry, that baby to that family. Okay, now, I already told you guys before, there's a lot more focus now in keeping babies in their rooms, but there's still times it goes to the nursery or goes to the procedure room. Anytime a baby leaves its family, when it's brought back, they need to check the bands together and match those numbers. So like the places I've worked, it's like a letter and then 4 numbers. You might say like D 1 2 3 4 5 or C 8 7 6 3 3. And that's on all of the bands. So you're gonna look at both of them together and match them before you leave the baby.
Do you check with the mom and the support person?
No, just have to check with one of them.
So on that, you said that the baby gets 2 bands, so either 2 legs or an arm and a leg. Are those both the same thing, or is one the security band and one is the
No,
leg?
for the actual number one, they're the exact same.
Okay.
So they're just gonna have an extra one because with their potential for birth weight loss, they can start to slip off. So sometimes we have to put socks on their hands, gloves, so they don't slip off.
We cut little socks and they go like little armbands.
Yep.
And then that alarm goes off always too.
Yeah, that one's fun too. Did that answer your question, Stephanie? Okay.
I was just making sure, so they would have a total of 3 on then, with the
Um,
security, or is the security?
No,
taking-
yes, I'm sorry, yes, there'll be 3 total on the baby.
Okay.
2 of them look exactly the same.
On the ones that-
Yeah. Okay, so we're still talking about those ones, about pairing the family together. Okay, the other thing is, when you're teaching parents about that, you need to tell them whatever other protocols go with that. So for example, When I worked at Boone Hospital, we would go get our name badges when we got hired. Everyone that worked on the OB floor like I did, their badge looked like a Boone badge, but it had a pink background. No one else's did. Because that was signifying this badge allows me to get on this locked unit and it shows that I'm a safe caretaker on this unit. So we would tell the families, do not let your baby go with anyone unless they're wearing a pink badge. Why do you think we would do that?
There's safety precautions.
Yes, and if you look back at some of the actual infant abductions that have happened, a lot of times they try to dress like a hospital worker, like a housekeeper or a nurse's aide or something. So they'll look like they're hospital personnel, and you want the family to know to look for the pink badge. St. Mary's has scrubs that have like baby footprints on them, and those are only in their locker room. They're not throughout the hospital. So they tell them to look for those scrubs. Okay, so that is a security factor as far as keeping it with the right family. Okay, the other type of infant security is more of a physical safety, and it looks like a house arrest bracelet. And the unit is a locked unit. So these little security tags, if you get too close to an exit, or one of the doors to the outside of the unit is open and you get a baby too close, an alarm will go off. And everyone activates, assuming it's an infant abduction. So this is more of a physical, like trying to prevent kidnapping. The other type was trying to make sure the right baby stays with the right family. Okay, the reason, why do you think I'm tying this into assessment?
Because you need to make sure that these things are done.
Yes. When you do your assessment, regardless of if you were there for the birth, these things are part of the assessment. Do you remember when I told you in Super Lab that I have taken care of moms about to go home that didn't even know they were supposed to be washing with a water bottle? What if we catch one that didn't get one of these put on for whatever reason? Maybe they had 5 births in an hour and the whole place was falling apart. We might catch something that can save a life in a different way than we're used to saving lives. So you need to know what's normal where you are. If it's to have 2 bracelets for the mom and dad pairing, make sure those are both on. You do your assessment. And if one's missing, we need to find it. Sometimes it falls off from the blankets, yada yada. Yes, they have the second one on, but what if that one falls off? You gotta find the second one. Okay, so you're gonna make sure both of those are present. And then you're gonna make sure that the house arrest one is present. And then usually there is a way to tell whether it's on, whether it's got a red light on or something that tells you it's functioning. Does that make sense? Because these things are useless if they're not activated. And usually when they activate them, they will pair it with the family. So that when it's going off, they'll know which baby is setting it off. So make sure you check that it's present, and then if there's any other factors like a light flashing or whatever, that we do that. A lot of times these can't get wet, so they'll deactivate and take them off for a bath. Make sure you then reactivate and put it back on. The other thing too, I can't stress enough to you guys, is that it is, I'm gonna switch back to the ones that pair the mom with the baby. It is better to overcheck than undercheck. You can't check enough. It doesn't matter if you were the one that stayed with the baby the whole time, you took it to the nursery, it got its hearing screen, and you brought it back and it never left your sight, you need to check the bands. If this helps at all, my very first shift as a new grad at Boone, very first shift, I worked in the nursery, and the night before, one of baby to a mom to breastfeed. They didn't check the bands, and the mom was woken up and said, "Why is he wearing a different hat?" And they didn't check, and she breastfed the wrong baby. Now, as a new grad, I can tell you that was very impressionable to me, that I never ever want to do that ever. So we had to do lots of blood draws to make sure HIV, Hep B, Hep C, because those can spread through breast milk. And there was bodily fluids touching. But can you imagine being that nurse that did that? No. I've also seen babies switched when we're really busy in the nursery and we're doing a bunch of baths. I've seen someone have, this is back when we had 25 babies in at one time. They put the baby on the warmer, its crib is right next to it. They do the bath, yada yada, and they take it off and put it in the wrong crib. So the little card that says Baby Smith, you just put the baby in the wrong one. So that can cause some issues, which is why we check. Because if you check, you're going to catch it. Okay, any questions? When you guys get oriented, you need to find out what the check process is, and then you need to know how to do that every single time. Okay. Okay, nursing diagnoses. So, what are some examples of nursing diagnoses for postpartum women? Some general ones that will relate to many postpartum women. Acute pain, good job.
Altered mobility.
That's a great Metzger answer, yep. Altered mobility, sure. How come?
It could be on like narcotics.
What's an even bigger reason to probably have epidural? Yeah, a lot of them have epidurals or spinals at first, so there's going to be altered mobility with that.
Risk for infection.
Okay, risk for infection, why?
Just had a big placental thing just ripped from their body.
Okay, so there's a big placental wound, sure. Why else do they have risk for infection?
Well, how long was the war?
Okay, good job. Not the range of motion, right?
Yeah.
Ruptured membranes. Okay, how long were they ROM'd? Sure, what else?
Laceration.
Okay, lacerations, did they tear? If so, was it a first degree, a third degree, a fourth degree? Did they have a C-section? If they did, they're gonna have a big wound from that as well. Actually, it's not that big, but it's deep. What else?
Knowledge deficit.
Well, yes, but what else? Why else do they have a risk for infection? Keep going with that one. Why else are these moms have a risk for infection?
Shower with the
Okay,
Breastfeeding.
Is that you or you? Oh, breastfeeding, how come?
You could acquire mastitis over time.
Okay, that's a good thought. Yeah.
Yeah, from like breaks in the
Yeah, especially breastfeeding in and of itself, typically we don't think of as a big, but you're right, you're not wrong by saying that. But especially if they have broken skin. Or if we know their baby has thrush or something, that's a big one. What else? Why else are these women at risk for infection?
with our technique, and I don't know how to use it, like face up with
Oh, and what specific do you mean by tip? From us or?
Yeah.
Okay, so you're saying healthcare worker choices?
Yeah.
Is that what you're saying? Okay.
Oh,
So the fact that there's multiple caregivers, sure.
I was gonna say they in the hospital.
Yes! Sadly, just being in a hospital puts you at risk. It seems backwards, right? Very good. Their immune system's a little bit relaxed.
UTIs, especially if they had like a full UTI.
Absolutely. They had something, many of them had something invasive in their bladder, right? Even if we use the best technique ever, it is a direct line for things to crawl up, right? What else? Lots of things left. You're doing great, but there's still lots. IVs, right? That's just like a Foley, except for the baby.
As you say, somebody said hopefully.
Yep, somebody said Foley, so IVs are like that, what else?
I don't know, this is one, but like whenever making sure that the equipment that you, like the stuff that you use to do peri care is clean.
Okay. So, the items they use for
Yeah.
hair care? Sure.
Is there like one that you're like looking for in particular?
There's a few I have left in my
Okay.
mind. You guys have gotten a lot of them, but there's still some in my mind. Because there's a lot of risks for infection, right?
What about like her not taking like her hygiene, and using the periodol and using the
Okay,
things she
so whether she's choosing, okay, so her personal choices, sure. So there's a Foley, there's an IV. Yes. Have you guys ever seen one of those put in?
Yeah, they
It's
would.
quite invasive.
Yeah.
It's a great place for bacteria to try to get in. Thankfully, they usually don't. And the anesthesia team is usually very sterile in their procedures. What else?
Cervix checks.
Yeah, how many cervical checks did she get? Were they done sterilely like they're supposed to be? Sure. We haven't learned about this yet, but some of the monitoring that we can do during labor, they can put, yeah, there's external ones, but both of them can, there's also internal ways to do it. So those go up through the vagina into the uterus. So those, if they're present, would be risks for infection.
If there was a problem with the placenta and having to go.
Good. If they had to do more, they had to be more invasive to get out the placenta, or had to do more manipulation within the uterus, that's a potential for infection. Think about these families too. Who's gonna be coming to visit them?
Everyone and no matter.
Every one of their brother thinks they're the most important visitor to come. And I'm thinking if this baby has older siblings with runny noses that just got out of daycare, they're gonna share all their little germs and stuff. Before COVID, kids could come. Yeah, yes,
Well, the
before
hospital I
COVID.
was at, I think 6 and under weren't allowed to come for like.
I've typically not seen an age limit. I have seen posted rules about if they're sick or if the kid's sick, they shouldn't come, but I haven't seen the best, like, let me take your temperature, child. So a lot of it's honor system, at least around here. Yeah. All right, and then keep in mind, other things are, you know, the COVID pandemic. That's a risk for infection, environmental one. You could even tie things like, has she had her flu shot? Has she had her Tdap vaccine? Those types of things tied to infection risk, right? What else could we put for infection risk? Any lab data we could put as an indicator? What their white blood cell count is, sure.
What if she has like autoimmune?
Yeah, sure. If she has HIV, if she has Hep B, if she has herpes. Okay, good job. All right, I think someone said knowledge deficit, right? Why would that be a good nursing diagnosis for postpartum moms?
I've not done it.
Huh? That was a lot of.
If they've never done it, they don't know.
Okay, so especially if it's a first time mom, sure. But not just first time moms.
Like, I was gonna say, like, every baby is different.
Yes.
How
You can be a great parent to your previous children, and then the next one can come along and throw all sorts of curveballs we weren't ready for. Maybe the last baby didn't have jaundice, and this one has terrible jaundice and has to have Billy lights, and they don't understand. Okay? What else about knowledge deficit? Yes. So if they haven't breastfed before, or even if they have a new baby, could be higher maintenance. Or maybe it's born with a cleft lip. That presents challenges with people.
Care, whereas like if the first delivery they didn't have care.
Sure.
Or if they did like a C-section and then did a vaginal.
Yes,
Yeah.
very good. How to care for the different birth routes. Exactly. Sure. Okay. What about nutrition?
Like the breastfeeding.
Sure. Could increase their iron intake. Okay. Very good. What else?
What about like, knowledge deficit, like is it, like if they're taking a lot of pain meds or anything, or constipation, like they need to know?
Sure.
what
Yeah.
to do
Side
for that?
effects. Sometimes they have a knowledge deficit of what meds they have available to them. I always get frustrated when you have a lot of PRNs on postpartum, and it always aggravates me when I take over on a patient and have no idea that they have a stool softener available, or they have this available, or
Or what about like the meds they can take while breastfeeding too? A lot of
Okay.
them don't know what they can and
Sure.
can't take.
And a lot of them don't know that it changes from what they can take over the counter while pregnant. It can change what they can take over the counter during lactation. Those things they're different states of being.
Should continue taking prenatal vitamins.
Okay, prenatal vitamins, continuity. All right.
No, I was just gonna say like if we.
Yes, that's what I was going for. You guys are doing all these things about her, how to take care of the baby. Diaper changes, how to swaddle, car seat, hunger cues.
Sleeping.
Sleeping, sure. What's normal with sleeping?
What not to do at night.
Okay, safe sleeping. Super. All right, any other, I guess we covered risk for infection, so any other risk for or non-risk fors that you can think of? Yes. Risk for bleeding. I would like to give you a hint if you're in OB first, that the majority of the time, risk for bleeding is gonna be number one. On that document, more than I showed you, where you have to rank top 5, it's pretty hard to top risk for bleeding as number one. It's possible. So why is risk for bleeding an appropriate nursing diagnosis for postpartum women?
It can happen to you.
What,
It can happen to any mom.
hemorrhaging or?
Yeah.
Yep. I would say if she's postpartum, wouldn't risk for bleeding literally be a nursing diagnosis for every single postpartum mom? Very rarely can we say that, right? But in this case, we can. Okay, what other factors about a mom might be indicators that risk for bleeding is important? So she's postpartum status, she has the placenta that came out. What other things about her? If she got extra medications after delivery, that would be an indicator. What she's currently on, okay? Well, yeah, what was her starting age and age? Okay, if it took a long time for the placenta to detach, if it came out in segments, how long she pushed, can sometimes impact things. Okay, there's a sample nursing care plan on 469 to 71. Make sure your outcome relates to your diagnosis. So your nursing diagnosis drives your outcome. And then the interventions you come up with aid in achieving the outcome. All right, so let's just say our nursing diagnosis is risk for bleeding. What kind of outcome could we write that relates to risk for bleeding? Yeah, you could say within this range, or above whatever number, okay? Or continue, you say continue increasing?
Yeah.
Okay. So you could say continue increasing from this starting point, whatever it is. So you wanna make it specific, but there's our outcome. Now, our interventions aid us in achieving the outcome. So if that's the outcome that we just set, what interventions are we going to do to assist with that? Okay, bundle checks? You say push fluids, okay? Okay, transfusion if needed. Okay, assess how much lochia you're seeing. Sure. What else? If I, as the nurse, am trying to accomplish the outcome we just came up with, what else can I do to help keep H and H levels where we want them? Yeah, check the labs, monitor them. What else can I do? Somebody said massage and fundus, right? Somebody said check her lochia.
You can have her like ambulate because there's just no signal and passing large amount of clots like after she's been that many.
Yeah, that's a good thought. Part of what I'm thinking is, would she have already been passing that blood?
It's just coming out.
It's just sitting there is why. So it's not that sitting there is making it heavier, it's just sitting there and cooling. However, I think ambulation is still a good thing just for like DVTs. What else can we do if we want to help with her H and H?
Did you say give Pitocin?
I think you said that, didn't you? Give Pitocin. Okay,
Nobody did.
maybe that's a different answer. Yes, so administer Pitocin per orders. Okay. Okay. Think about our quiz today, guys. There we go. Avoid bladder distension. Teach her to empty her bladder routinely. Okay. Okay, outcomes and planning for discharge. When do we start planning for discharge? The minute she gets there, you're right. Her first interaction with the nurse. What determines our length of stay? How they're both doing, how the baby was delivered, correct? Okay. Typically, they start the day over at 12:01 a.m. So, you can stay 2 nights after a vaginal delivery and 4 nights for a C-section.
What time did you say?
12:01 a.m. is when the new day starts. So here's the deal, guys. If you deliver at 11:55 p.m., 5 minutes later, or 6 minutes later, you've now stayed your first night. So it goes at midnight. So I typically tell people if someone delivers at 1 a.m., they essentially get a whole day more than someone who delivers at 11:55 p.m. the same day. Because both of them, when the first midnight hits, they both stayed their first night. Does that make sense?
So you say vaginally is 2 and C-section
2
is
nights for
4.
vaginal, 4 for C-section.
Most people know that have C-sections do that long.
I'd say most people stay 3 nights, some do 2, some do 4. But usually we always say the 4th night is just a bad idea to be at home. That's when all the problems that's when everything is falling apart. These stays, I think the average stay shortened tremendously during COVID. There was a big push, both by families and the hospital environment, to go home as soon as you can, just for the safety of getting out of an environment where there's more rampant COVID. Okay, the third bullet there, the Newborns and Mothers Health Protection Act of 1996. This essentially required that insurance pay for those time windows I just said. They have to pay for a 48-hour stay for an uncomplicated vaginal delivery and a 96-hour stay for an uncomplicated C-section. Yeah, that's 4 days. In the 90s, there was this big trend that insurances were not paying as much or were paying way less, and so people were going home before 24 hours, and that didn't go well. That's not a safe thing to do. Some people can do that and be fine, but we shouldn't be pushing people out the door that quickly. One other thing I wanted to say is sometimes the baby needs to stay longer for weight loss, for jaundice, for other issues. And so sometimes they'll discharge the mom, like as a patient, but the baby will stay, and then the mom will stay there with the baby, but is no longer a patient. So you have to make it very clear to her, like, we can't bring you medicine anymore. One thing that's really cool though is a lot of times hospitals will feed those moms if they're breastfeeding, because they're feeding the baby. So they'll give them cafeteria trays for free because they're feeding the baby, if they're breastfeeding. Okay, we need to make sure as we're planning for discharge that we're considering the unique needs of each couplet, and then provide the care needed to coordinate those needs. Remember that timely physiological interventions and treatment help to prevent morbidity and hospital readmission.
Hi, Mrs. Dahlstrom. I'm good, how are you?
Okay, and then I put a quote here from page 468 that I really like. Hospital-based maternity nurses continue to play key roles as caregivers, teachers, and advocates for mothers, newborns, and families in developing and implementing effective home care strategies. One other thing I wanted to mention is that how discharge teaching is done is different everywhere. Some have videos you're supposed to watch on those like circuit TVs, like watch these videos before discharge. Others just do some face-to-face teaching and have the parents sign off. But you want to make sure you follow the post-partum order sets and the teaching checklists to make sure all the different education outcomes and care tasks are covered. Okay, nursing interventions. Again, we're individualizing care based on the mom and baby's needs. The nurse should plan with the woman which interventions are appropriate and which are given priority. And our plan of care needs to include the following. Routine assessments to detect any deviations from normal. Actions to relieve pain and discomfort. Safety measures to help prevent infection and injury. And then ensuring that we're teaching them and providing counseling measures to promote her feelings of competence and managing her own care and managing that of the baby. We want to make sure that we incorporate her support system, whether that's a partner or a spouse, her family, into the teaching and counseling. And then we also really want to ensure we're using something called anticipatory guidance. What is anticipatory guidance?
So just being aware of the things that could happen so that you're planning accordingly for them.
Yeah. It's like teaching ahead of time. So they, like, we don't want to wait till there is a problem to suddenly do all the teaching for it. Nor can we teach for everything that could possibly come. But it's just like I mentioned in Super Lab about how much pain is normal in breastfeeding. Even if everything's going well in the hospital, one example of anticipatory guidance would be while you're assisting a mom with feeding, you might say, are you having any pain or discomfort during this feeding or in between? And she may say no, which is great. But then you can say, okay, wonderful. I just want to let you know that with breastfeeding, it's normal to have some mild discomfort for the first week. If you experience anything more than mild discomfort, or you start having skin breakdown or skin problems, you need to reach out to the lactation consultant at this hospital. Or you need to call the pediatrician for the baby. So you've now told her the limits of normal and what to do if she gets outside of that. Does that make sense? And we don't have to dive into all the different things they might do for nipple pain because she's not there yet, but we've told her where to go if that does occur. Okay, the book also does a nice job of incorporating the concept I talked about before, where anything we can do to help increase the mom's self-confidence can be very helpful to her. They use the term mothering the mother. So she's excessively focused on her baby. We need to make sure we're helping her take care of herself as well. So providing her some of that care. Nurture her by providing encouragement and support as she begins taking on the tasks of motherhood. And again, this isn't just the first time she becomes a mom. I've taken care of a few moms who have had 10 or 12 years between their 3 children. So they might be like, I can't do this. I'm 42. I have grandchildren. They might need some of that confidence because they're starting over. Well, they didn't expect that they would. Maybe they have twins. I think I gave you guys an example before, not to assume that just because somebody's having their 3rd or 4th baby, they know everything. We've taken care of plenty of moms before who are breastfeeding for the first time with their 4th child. It'd be really easy to assume, oh, she knows what she's doing, this is her 4th baby. But if it's her first time breastfeeding, she's going to need a lot of support.
Situation if someone, let's say, is experiencing infertility, is that when you catheterize to make sure that their bladder is not distended in time, or?
Oh, we'll talk
Oh,
about
you
that in a
just mean-
second. Yes.
oh, sorry.
No, that's fine. When we get to that part, we'll talk about all the different interventions. Okay, so let's start with maintaining uterine tone. So we can restore good tone by trying to stimulate the muscle fibers of the uterus with gentle massage until it's firm. Explaining what we're doing to a mom can help increase their cooperation greatly. every mom is gonna respond to that differently. Some will clench as soon as they see you and say, oh no, you're gonna rub my belly, aren't you? Others, you can do whatever and they don't act like they can feel it. So just be very mindful that for some women it's incredibly tender. She's also able to massage her own fundus if she wants to. So it's not wrong if she wants to feel where her fundus is and do her own routine massaging, that's fine. I don't tend to just teach that to everyone, but if they ask me, I will happily involve that. Okay, while we're talking about blood loss, I want to discuss reliable indicators of when we know they're hemorrhaging too much or they're unstable. So what do you guys tend to think of as one of the best ways to figure out if someone's lost too much blood? Pads? Think outside of OB though. What if somebody was in a car accident or they're hemorrhaging out of like a surgical wound? Yeah, we often think blood pressure, right? Okay. What'd you say? Consciousness? Okay, decrease in level of consciousness. What goes along with blood pressure? Yes. Okay, so we often think that if blood pressure is dropping and pulse rate's going up, they could be bleeding out somewhere, right? Okay, here's what you need to know in this specific area. Blood pressure is not a reliable indicator of shock in early postpartum hemorrhage, early meaning in the first 24 hours. Why? That stinks. Why do you suppose blood pressure? Okay. Good guess. Okay, maybe their blood pressure is increased or off for other reasons. What'd you say, Sarah?
No, I was just gonna say.
Okay,
that
it's
background.
because they're young, they're healthy, their autonomic systems, their sympathetic and parasympathetic are toned and responsive.
So since we talked about like how today we have like wellness center.
They're still way younger and healthier than most med surg floors. They're still 20, even if they're 40 years old and overweight and diabetic, they're still going to be healthier than someone with those same characteristics that's 60 or 70. So these moms can often lose 30 to 40% of their blood volume, and physiological compensatory mechanisms will preserve their blood pressure. Physiological compensatory mechanisms. Now those are a bunch of million-dollar words put together, right? What the heck did I just say? What'd you say?
Her RAS system will activate.
Possibly, yeah, her RAS system. She has a strong heart. She's gonna have plenty of blood probably too, because blood volume goes up during pregnancy. She's relatively young, she's relatively healthy in the grand scheme of your lifespan. So her body is gonna do all sorts of things as it feels blood going out and recognizing that the blood volume is decreasing in her body. What's her body gonna do? Some vasoconstriction, right? If you vasoconstrict, you can have a higher blood pressure with the same blood volume, right? It'll also shunt blood to the proper organs or the more important organs. So many of her vital organs will be in good condition even if she's hemorrhaging out. So all of that is to say that we should not look at blood pressure when we're dealing with a hemorrhage patient and say, she seems fine, her blood pressure is 120/80. It doesn't matter. It's not gonna start to show us till she's lost almost half the blood. We don't wanna wait that long. Okay, so some things that are good indicators or better indicators of shock, better than blood pressure. Some of you guys already said. So level of consciousness, urine output. Why is urine output a good indicator? What? They're not only just still functioning, they're producing enough urine. That means they're being well perfused, right? Okay, respiration rate. Pulse. And skin condition. So tell me about respiration rate. Why does that one tie to blood loss? Or why would a change? Why is that a problem though? What does that have to do with breathing? Why would blood loss somewhere else tie to my breathing rate? There you go. So blood's carrying oxygen, right? So if you're bleeding out, the body is starving for oxygen in certain tissue. So the body's going to kick into gear and say, something's not going on here. I need more oxygen. So that's going to be a better indicator than waiting for the blood pressure to drop.
Is your heart rate still gonna increase?
Yeah, pulse is going to go up. What does skin have to do with? Skin condition have to do with hemorrhaging?
Their circulation.
Hail. Temperature. What temperature do you think it might change more to? Cooler, right? And those make sense together, right? If you're getting paler and cooler, it's because you don't have enough blood to keep you warm, right? It's all being pulled to the inside of your body. There isn't, the periphery is the least important, right? Your arms and legs are the least important. The vital organs are central. It's gonna pull blood or not give you as much to perfuse the vital organs. You're gonna get cold. What else might they do? Shiver. They may even sweat a little bit, right? Okay, and then we talked about urine output, we talked about level of consciousness. Those respirations, pulse, skin condition, urine output, and level of consciousness are better indicators of hypovolemic shock than blood pressure.
Urine output actually goes down.
Pardon me?
Urine output goes down.
If you're in shock, it does go down. If you have good urine output, that's a good indicator of stable blood status. So all these things that I'm going over, this is why when a mom first has a baby, you guys will see this when you're at clinicals. We do, and it's a little bit different everywhere, but similar concept. We do like these routine checks. And it's like every 5 minutes for 15 minutes, every 15 minutes for an hour, every hour for 4 hours. And we check their fundus, we check their bleeding, and we check vital signs. And that's why. Is because you're more likely to hemorrhage early on. And that's what we're watching for, is subtle changes. Okay, remember that blood loss is usually a subjective measurement. What does that mean, subjective?
It's not objective.
Very good. Win the day, everybody. That was a very brave answer. I can't argue, you're right.
It's hard to measure.
Yeah, I typically think the word subject means it depends on the subject looking at it. I might assess it a different way than Kyrie, than Nisa. The subject is going to interpret it different. So it's subjective to the subject's interpretation. What are some things that would be better objective indicators of blood loss?
Hemoglobin.
Yes, hemoglobin and hematocrit values, and you can do what's called serial ones, S-E-R-I-A-L, not like breakfast cereal. So we can do them, before delivery, an hour after, the next day, etc. And we can compare those. What's the trend? That can tell us a heck of a lot more than trying to guess how much she's bleeding by looking at it. Anything else that's objective that could give us an objective way to measure blood loss?
You can weigh the pads.
Yeah, you can weigh clots. You can weigh saturated items. If you know that this pad holds, say, 200 mils and it's saturated, you can eyeball that. Or you can do like, you know how you put like a dry pad on and then zero it and then put the soaked one on? That'll give you the difference. That'll give you, and it's generally 1 ounce to, or not 1 ounce, 1 gram to 1 mil of blood loss. Okay, and then again, you can keep an idea of the time factor when you're measuring. We talked about that before and how important how much the bleeding is over what period of time. Okay, on your med profile that you guys turned in, what medications that were on your med profile relate to the bleeding nursing role? Pitocin, okay, and remind me what Pitocin is gonna do to postpartum moms. Contract, control bleeding, right? What is Pitocin? Synthetic oxytocin, correct. Okay, there's one other medicine on there that distantly relates to this one. Was that on there?
You know.
I don't think it was on.
Oh, it was
there.
on Mindy's, sorry. It was on
No,
hers.
it was on the guys.
Yeah.
Oh, yes, it was on the one about, yes, but it was
wasn't
on,
on
yes,
Sorry.
good catch. Yes, that would help with bleeding, but it's not on the initial profile. It will definitely help with bleeding. Is there anything on there that's not necessarily gonna help with a hemorrhage, but relates to this blood loss concern? No, good guess. What, turbidolene, not turbidolene?
That's what I was going to.
There you go, the prenatal vitamins. It's distant, but what the heck's that gonna have to do with this?
Does it have iron?
It does have iron. So she should have been taking it during pregnancy, right? We often continue it after delivery, but that iron component can help rebuild blood supply lost slowly. Alright, let me just go through prevention of infection and then we'll be done for today. Okay, oh, I'm sorry, I didn't talk about bladder distension. I promised I would. So sorry. Okay, so we talked about maintaining uterine tone. Pitocin's gonna help with that, massagin's gonna help with it. We're gonna monitor objective and subjective signs. All right, why does preventing bladder distension relate to uterine bleeding? I want you to understand that from a physiological basis. Go ahead,
It
Lindsay.
can prevent the uterus from contracting. Because
Why?
the pressure of the bladder on the uterus.
Yeah,
Where
where,
give it enough
Go ahead.
room or space to do.
okay,
And it also pushes certain, like, indicate like the false positive of like location and stuff. in the
yes,
body.
it definitely can throw off our assessment, just getting an accurate assessment for sure.
It can make the uterus fall.
Yes, kind of. Tell me, because one of you guys said fall, one of you said prevent. Where are they anatomically? How are they related? Bladder's way down here, right? It's the bottommost thing.
If it doesn't subvolute, then it will hemorrhage. And
I know what you're trying to do there. You want to be, if we don't let the uterus stay clamped down, we're preventing involution, which is the uterus getting back to normal, which is what we call subvolution. Okay, so if the bladder is under the uterus, now relate what everyone was trying to say together. Cause you said fall, somebody else said.
It pushes it up and then it falls to the side.
It's a water balloon, right? That's literally growing like this. And the uterus is over it. And what's the uterus supposed to be doing as soon as she has her baby? Its whole job is to go like this and stay clamped, okay? Is there someone willing to come up here and make a muscle for us?
Not like this. Oh, I got that one.
Then I think they're volunteering you. No? Okay. Who wants to do it?
Thanks for taking one for the team.
Are you saying that the pressure? if you-
Hold on, I'm gonna give a demonstration. Do you mind making like a muscle for us? And then do you mind if I pull on your arm?
Yeah. That's
Yeah, you mind or yeah, you don't?
it's okay.
Okay. All right. This is kind of what it's like. So I want you to just make a muscle, like you're showing off, and don't stop doing it, okay? This is, I'm the bladder, and he's the uterus. This is what the bladder's doing. Resist me. Okay, at some point, isn't this muscle, no matter how strong it is, it's going to give way. So these are muscle fibers, right? You're laughing at us. These are muscle fibers, just like in a uterus. And we're coming, this is the bladder saying, I'm coming, I'm coming, I'm coming. At some point, that uterus is going to get stretched and stretched and stretched and give way. So it will fall to the side first, and then if it keeps getting stretched, those muscle fibers that have been clamping down that give us the firm feeling are going to give way. Thank you. So anybody can be super strong, any uterus can be super efficient, but at some point, those muscle fibers are going to be stretched beyond their capability to hold against. Does that make sense? Okay, so when you think of a uterus, think of a bicep. It's just it's more rounded, globe-shaped shape at the time. And it's all muscle. So if that bladder underneath of it is just pushing it up, all those fibers are getting stretched, and they can give way. So we know if it's off to the side, that's usually an indication the bladder is being a problem. Why might a mom have trouble feeling the urge to urinate, or even if she feels like she needs to urinate, not be able to? What are some things impacting that ability?
Epidural sensation.
Epidural sensation?
Just the trauma that her body's been through.
Okay, just having a baby, even if it's a normal sized baby, go through that narrow region, even if nothing tears, that's a lot of tissue. I don't want to say trauma because it's not like it tears, but it's tissue altering. Everything's getting pushed around and shoved in places it's not usually. So those things can still be out of whack. What else? Is it impacting her ability to feel like she needs to pee or to be able to pee? What?
Dehydration,
Possible dehydration.
mobility,
Even if she can get up though, a lot of times they can get up to the bathroom, they feel it, they know they have to go, and they just can't.
their muscles completely like, it's not gonna contract for them.
Okay. So something with muscle reaction.
If they have that issue, how long does it take for that sensation to come out?
It's usually pretty quickly. I'll go over in just a second, kind of the natural. A lot of times, like the more time that goes by, the more women that can go. Maybe they can't go the first time. We in and out happen one time, and the next time they can. Okay, so here's some other things. If she had an epidural, if she had a Foley in for any length of time, if she had any tearing or repairing done, that can impact. If she had a really long labor, or if she pushed for a really long time, if they had to use any sort of instruments like a vacuum extractor or forceps, that can impact. urination. And then for C-section moms, they have Foley's in longer. So sometimes when you take out their Foley the next day, they have the same issue where they haven't had to pee for like 24 hours because it's just done for them. So sometimes they have trouble with that sensation. The other thing is, remember, they were pregnant for 8 or 9 months with a giant abdomen pushing down on their bladder and urethra, and that can alter functionality. Okay, so if we know a mom has a distended bladder, or we just know, yeah, it's time to empty your bladder. If she can't walk, we can give her a bedpan. If she can walk, we'll get her up to the bathroom. Sometimes it takes a few minutes, so we can let them listen to running water. Sometimes if they put their hands in warm water, that'll help them pee. You can give them like warm water in the peri bottle, and sometimes that can just help stimulate the urge to actually urinate. If they do a sitz bath, that can help. If there's warm water in the shower. If they still can't go, especially if their bladder is distended, then we need to in and out cap them. If it's been a couple hours since delivery, but her fundus is still firm and one below, she doesn't feel like she needs to pee, and we're not seeing any indication, you don't have to in and out cap her. We're only going to do that when we feel like there's bladder distension and she's unable to empty herself. Okay, so typically what I see done is when they need to urinate from bladder distension and they can't, typically they'll say in and out cap one time. In and out cap them, say you empty out 700, okay, she's going to in and out cap and say 1235. Then they're going to usually give them 6 to 8 hours to pee on their own. Now we're not going to wait that long if in 3 or 4 hours her fundus is firm and right and up in her ribs. We're not going to wait 6 or 8 hours, but up to 6 or 8 hours as long as her uterus and bladder aren't distended. If within that time frame her bladder is distended again, she still can't pee, we've tried everything, then typically what they'll do is place a Foley and leave it in like 24 hours or until the next day. And it kind of gives her a break. And then after that comes out, most moms have full functionality back. I can think of 1, maybe 2 moms I've ever heard of in all the places I've worked or talked to girls that had long-term bladder urination issues. It's very rare. Usually it's just a body sensation waiting for everything to come back to it properly. Okay, any questions on excess bleeding role? You guys did a great job today. Sounded like you did a great job on the quiz. Keep up the great work.